All right, let's get right into it. When we talk about obesity, it's really easy to frame it as just a lifestyle issue. But in the world of medicine, and especially in anesthesia, it's a completely different story. It's a profound physiological challenge, one that pushes our modern medical skills right to the absolute edge. This isn't about choice. It's a complex disease. And trying to manage it during surgery, well, that's like walking a tightrope.
And just to be clear, we're not talking about some rare condition. To really get the stakes here, you have to start with the scale of it. Globally, we're looking at 1.9 billion adults who are overweight. And of that group, over 650 million are classified as obese. This is, without a doubt, one of the biggest epidemics of our time, and it's a reality that shows up on the operating table every single day.
So, if we're going to walk that tightrope alongside an anesthesiologist, we've got to understand what we're up against. First, let's really break down the numbers and the nature of the disease itself. Okay, this definition is key. Medicine sees obesity as a physiologic dysfunction. What does that mean? It means the body's fundamental systems just aren't working the way they should be. And it's not one thing. It's this complex web of genetics, your environment, and your hormones all tangled together. It's a disease, plain and simple. And it's actually the second leading preventable cause of death, right behind smoking.
So how do we classify it? We use the Body Mass Index, or BMI. And what you'll notice here is that the risk of serious health problems doesn't just go up, it skyrockets. You move from increased risk to high, then very high. And then look at that last one, super obese, with a BMI over 50. The risk is literally classified as exceedingly high. The danger just compounds with every step.
So that's the big picture. But what does this disease actually do inside a person's body? We've seen the scale of the epidemic. Now let's zoom in on the individual. We're talking about a body that is under a constant state of siege from within.
And this chart really tells the story. See, obesity almost never travels alone. It brings a whole crew of other diseases with it, what doctors call comorbidities. We're talking about a cluster of major problems: type 2 diabetes, heart disease, increased cancer risk, and a huge one for anesthesiologists, obstructive sleep apnea, or OSA. It's like a package deal of health crises all rolled into one.
Let's zero in on one of the biggest players here, metabolic syndrome. Now, this isn't just one single disease. It's a whole collection of risk factors that, when they show up together, dramatically crank up your chances of having a heart attack, a stroke, or developing diabetes. And that number? Wow! It affects over a third of all adults in the US. It's one of the main, devastating consequences of obesity.
So how do you know if you have it? Well, it's surprisingly straightforward. A doctor just looks for these 5 things. And you only need to have 3 of them to get the diagnosis: a large waistline, high triglycerides, low good cholesterol, high blood pressure, or high blood sugar. When you see it laid out like this, you really start to get how all these systems are connected.
And then you've got sleep apnea. This quote just says it all. Obesity is the #1 cause, period. All that excess tissue in the neck and throat can actually cause the airway to collapse during sleep, which makes a person stop breathing over and over all night. This starves the body of oxygen, puts a massive strain on the heart, and, as we're about to see, it makes managing a patient's airway during surgery an incredibly high-stakes situation.
Okay, so you have this incredibly complex and devastating disease. The big question is obvious. What can we actually do about it? Let's take a look at the most effective tools we have in our arsenal today.
When you put the treatments side by side, the difference is just stark. Non-surgical options like diet and medication, they're aiming for a pretty modest 5 to 10% weight loss. And let's be honest, the results are often temporary. Bariatric surgery, though, that is a whole different ballgame. The goal here is to lose over half of your excess weight, and the results tend to be long-term and durable because the surgery fundamentally changes the body's metabolism.
And if you want proof of how powerful this is, look no further than its effect on type 2 diabetes. With just medical treatment, remission is, well, it's pretty rare. But after bariatric surgery, the remission rates can jump as high as 85%. This is the proof right here that this surgery isn't just about losing weight. It's a metabolic intervention so powerful it can actually reverse a disease.
Which brings us, finally, right back here, to the operating room. This is the place where all those numbers, all those comorbidities, all those physiological changes, this is where they all converge at once. And for the anesthesiologist, guiding that patient safely through surgery is the ultimate high-wire act.
So, what is it?
What exactly makes it so incredibly difficult? Why do we keep calling it a tightrope walk? Well, it boils down to a few critical high-pressure challenges: securing the airway, keeping the lungs ventilated, and calculating the doses for incredibly powerful drugs in a body that's just physiologically different.
The first, and maybe the most critical challenge of all, is the airway. Patients with obesity have less lung capacity, which means once anesthesia starts and they stop breathing on their own, their oxygen levels can plummet incredibly fast. We're talking sometimes in less than 3 minutes. This creates this super intense ticking clock scenario to get a breathing tube in. And the first step to winning that race isn't a drug. It's just a simple physical adjustment.
And that adjustment is all about positioning. The standard sniffing position we use for most patients often just doesn't work here. But this other technique, called the ramped position, makes a life-saving difference. All we do is elevate the patient's head and shoulders. It's a simple move, but it uses gravity to pull all that excess tissue down and away, aligning the airway perfectly for a clear view. It is an absolute game changer.
All right, next up, the drugs. You can't just look at the number on the scale and give a dose. It's way more complicated. Anesthetic drugs spread out differently in fat tissue versus muscle tissue. So the anesthesiologist has to do these really complex calculations on the fly. Some drugs, like the muscle relaxant rocuronium, are dosed based on the patient's ideal body weight. But others, like the sedative midazolam, have to be based on their total body weight. You get this wrong, you could either underdose them or dangerously overdose them.
And this, right here, is probably the most important takeaway of all. All these special techniques, the ramped position, the careful drug calculations, the unique ways of ventilating the lungs, they aren't just for people having weight loss surgery. Any patient with obesity, whether they're coming in for a knee replacement or to have their gallbladder out, they have the exact same physiological challenges. They all need and they all deserve this higher standard of care.
Which leaves us with one final and pretty heavy question. As this epidemic continues to grow and as more and more patients with these complex obesity-related diseases show up in our operating rooms, is our healthcare system truly ready? Are we equipped, trained, and funded to provide this incredibly specialized, high-stakes care, not just as an exception, but as the new everyday standard?